Hello again, this is Dr. Dakanay, and for this lesson, we'll be learning about neoplasms of the lung. So this is found in chapter 78 of your Harrison's 21st edition. So for the learning outcomes for this lesson, first we'll be learning about the epidemiology of lung cancer, the pathology, clinical manifestations, its diagnosis and staging, as well as management. And finally, we'll be learning about solitary pulmonary nodules. So for the epidemiology, lung cancer remains the #1 cause of cancer-related mortality or deaths. No? So overall, for all causes of cancer, lung cancer is still the most common cause of death. Tobacco consumption is said to be the primary cause of your lung cancer, with 60% of new lung cancer occurring in former smokers, usually more than 100 cigarettes per lifetime. And however, 1 in 5 women and 1 in 12 men are diagnosed with lung cancer who have never smoked. Lung cancer is said to be uncommon below 40 years old, but increases until the patients reach age 80. Its lifetime probability is around 8% for males and around 6% for females, with the highest incidence among your African American men. And it said that the incidence in mortality for Hispanics as well as Asians are less than your whites, no? Around 40 to 50% compared to your Caucasians. So cigarette smokers are said to have a 10-fold or greater increased risk of developing your lung CA. So it's 2,000%, no? So that's correct. 2,000% increased risk compared to your non-smokers. And this is because there is one genetic mutation induced for every 15 cigarettes that a person smokes. The risk becomes lower among those who quit smoking, especially if a person quits early. And your secondhand or environmental tobacco smoke is also an established cause of your lung CA. But take note that it's only a 20 to 30% increased risk compared to your non-smokers. Occupational exposures and ionizing radiation are also said to be risk factors for developing lung CA. For the pathology, the World Health Organization defines lung cancer as tumors arising from the respiratory epithelium, such as the bronchi, bronchioles, and alveoli. It's divided into 2 groups. You have your small cell lung cancer and non-small cell lung carcinomas. Your non-small cell lung carcinomas include the following: your adeno-CA, squamous cell CA, and large cell CA. So first, your small cell carcinomas, these are small cells. They have scanty cytoplasms, ill-defined cell borders, finely granular nuclear chromatin with absent or inconspicuous nucleoli, and a very high mitotic count. It can be distinguished from your non-small cell by your neuroendocrine markers, your CD56, or your neural cell adhesion molecule, NCAM, synaptophysin, chromogranin, and CK7. Next, you have your adenocarcinomas. Adeno-CA possesses a glandular appearance or differentiation, or it has a mucin production. They may show a cynar or a glandular appearance, papillary or finger-like, or lipidic, which is single-layered, or solid features, or a mixture of those mentioned patterns. Their immunohistochemistry markers would be TTF1, or thyroid transcription factor 1, NAPSIN-A, or NAP-A, as well as CK7. And the invasive adenocarcinomas are classified by the predominant pattern mentioned. Your squamous cell tumors, on the other hand, will show keratinization, and or intercellular bridges that arise from the bronchial epithelium. So these would appear as sheets of cells. And immunohistochemistry staining would reveal positive for your P40 as well as P63, which is similar to your other squamous cell tumors. And therefore, they are classified as keratinizing, non-keratinizing, and basaloid, again, similar to your other squamous cell CAs, such as the head and neck cancers. And lastly, we have your large cell carcinomas, which comprise only less than 10% of your lung CA. So this is actually a waste basket diagnosis, no? Meaning if the histopath shows lack of any cytologic or architectural features that demonstrates it to be small cell or glandular or squamous. So if it lacks any of those features, then this is placed in large cell carcinoma. Okay? So this is a diagnosis of exclusion. So shown here is a figure showing you the different appearances on histopath. You have your adeno-CA, which is glandular in appearance, your squamous cell CA, which are sheets of cells, your small cells, which are very darkly staining with a high mitotic count, and large cells lack any of the following mentioned features. You also see the relative frequency of the types. So you can see that adeno-CA is actually the most common form of your lung CA, followed by your small cell and squamous, and lastly your large cell. So all histologic types of lung cancer can develop in your current and former smokers, but your squamous and small cell carcinomas are most commonly associated with heavy tobacco use. So squamous and small cell are usually seen in smokers, while your adenocarcinoma tends to be the most common form of lung CA in never smokers, former light smokers, women, and younger adults. Shown here in this table and figure are the driver mutations in developing your non-small cell lung CA. So just to know that the most common driver mutations include your KRAS as well as EGFR. So it's important to know if there are any driver mutations because we now have targeted therapy for these mutations. Okay, so for the clinical manifestations, more than 50% of patients present usually with locally advanced or metastatic disease at the time of diagnosis. So unfortunately, most of the time when the patients come in, they're already at the advanced or metastatic disease. Majority of patients will present with signs, symptoms, or laboratory abnormalities due either to the primary lesion, local tumor growth, invasion or obstruction of adjacent structures, growth at distant metastatic sites, or even a paraneoplastic syndrome. A typical lung cancer patient is a current or former smoker, usually in their 60s, with a history of chronic cough with or without hemoptysis. But in lung cancer in never smokers, these are more commonly seen in women, East Asians, which includes ourselves, and tends to be younger compared to the typical cancer patients. For the central or endobronchial growth, so that means a tumor is growing inside the bronchus. You would expect the following manifestations. You have cough, hemoptysis, wheezes, stridor, dyspnea, and post-obstructive pneumonitis. While if your tumor is growing peripherally or close to the pleura, then you might encounter these manifestations. You have pain from the pleura or chest wall involvement, dyspnea because of the restriction, and even symptoms of lung abscess. Now, if there is tumor cavitation, then that patient might come in with fever, cough, purulent sputum, no? Similar to lung abscess patients. Patients can also present with regional spread of the tumor in the thorax. So this is usually contiguous growth or metastasis to regional lymph nodes. And this can be seen as tracheal obstruction, esophageal compression leading to dysphagia, hoarseness because of recurrent laryngeal nerve paralysis, and phrenic nerve palsy can lead to elevation of the hemidiaphragm in dyspnea. Also, patients can have Horner syndrome, dysystosis, meiosis, anhidrosis in enophthalmos because of sympathetic nerve paralysis. Patients can come in with malignant pleural effusion, so this can be seen as cough, chest pain, and difficulty of breathing. And rarely, patients can also have a Pancoast syndrome or a superior sulcus tumor. So this is a tumor growing in the apex of the lung, and it can involve your C8, T1, and T2 nerves. So these patients can present with shoulder pain relating to the ulnar distribution of the arm. Other findings can be your superior vena cava syndrome, cardiac tamponade, pleural effusion, as well as lymphangitic spread. Transbronchial growth can also be seen as impairment of your gas exchange or hypoxemia, dyspnea, and sputum production. And patients can also have nonspecific constitutional symptoms such as anorexia and weight loss, generalized weakness, as well as fever and night sweats. No? So nonspecific, very similar to your TB. So this table shows you the most common presenting signs and symptoms of lung cancer. So just take note that the most common symptoms are your cough, weight loss, as well as dyspnea. Extrathoracic metastatic disease is very common in lung CA. No? It can be found at autopsy in more than 50% of patients with squamous cell CA, 80% of patients with adeno or large cell CA, and more than 95% of patients with small cell lung CA. No? So metastasis, extrathoracic is very common. And the most common organs involved with your extrathoracic metastasis are your brain. So you have brain metastasis, which can be seen as headache, nausea, seizures, and neurologic deficits. Bone metastasis, patients can have pain, pathologic fractures, as well as spinal cord compression. Liver metastasis can be seen as hepatomegaly, right upper quadrant pain, fever, anorexia, and weight loss, while your adrenal metastasis rarely causes any symptoms such as pain or adrenal insufficiency. So this table just shows you the clinical findings which are suggestive of your metastatic disease. So if you elicit the following symptoms in history, there is weight loss more than 10 pounds, musculoskeletal pain, neurologic symptoms such as severe headache, syncope, seizures, weakness, changes in mental status, then you have to check for possible metastasis. On physical examination, if you encounter lymphadenopathy more than 1 centimeter, hoarseness, superior vena cava syndrome, bone tenderness, hepatomegaly, focal neurologic signs, papilledema or a soft tissue mass, then again, think of metastatic disease. And when you do laboratory testing for these patients and you encounter anemia, less than 40% in men and less than 35% in women, elevation of the liver enzymes or elevation of the calcium levels, then again, you have to work up these patients for metastasis. Patients can also rarely present with certain syndromes. No? So, for example, a patient having small cell CA can actually develop manifestations of your Cushing syndrome. SIADH can also be seen in small cell CA. Hypercalcemia can be encountered in squamous cell CA. You can have gynecomastia in large cell CA. No? So these paraneoplastic syndromes are because of the substances secreted by the tumor cells, no? Leading to these manifestations. Other manifestations, you can have connective tissue manifestations such as clubbing, hypertrophic pulmonary osteoarthropathy, and this can be seen in squamous, adeno, and large cell CA. You have your neuromuscular syndromes such as peripheral neuropathy, subacute cerebellar degeneration, and your Eaton-Lambert myasthenia, which are seen in your small cell CA, while dermatomyositis can be seen in all forms of your lung CA. Cardiovascular syndromes such as thrombophlebitis and non-bacterial endocarditis are associated with your adenocarcinoma, while hematologic as well as cutaneous syndromes can be encountered in all histologic types. So to diagnose a patient with lung cancer, tissue sampling is still required. But if you have a patient suspected of having metastatic disease, then biopsy of the most distant site is preferred over the actual mass. For example, if a patient has a right upper lobe mass, but there's also signs that there is involvement of a supraclavicular lymph node. So in that case, it might be easier to do biopsy of the supraclavicular lymph node rather than doing a more invasive biopsy of your lung mass. Okay? And if possible, core needle biopsy is preferred over fine needle aspiration biopsy to ensure that we get an adequate tissue sample for analysis. And this is very important because we also have to subject the tissue for your immunohistochemical staining. So there are different techniques by which we can get a sample for your biopsy. We can do a fiber optic bronchoscopy. We can do a transthoracic or percutaneous biopsy. So this is usually CT-guided biopsy. And we can also do your endobronchial ultrasound or EBUS. So this is a bronchoscopy but has a tip at the ultrasound at the tip of the scope, and that allows us to visualize the surrounding structures. So if there's a surrounding mass or lymph node, then a biopsy can be done on the surrounding areas. So if your tumor is centrally located, so it's found endobronchially within the bronchus or around the bronchus, usually this is seen in your small cell or squamous cell CA, then these lesions are usually more easily diagnosed with a bronchoscopic technique. But if your lesion is found peripherally or close to the pleura, such as in adeno and large cell CA, then these masses are usually more amenable to your transthoracic biopsy. Your EBUS is a good diagnostic test, especially if you have lymph nodes that are surrounding your bronchus. You can also do a percutaneous biopsy if you have suspected metastasis or involvement of your lymph nodes. You can do cell block if the patient manifests with pleural effusion and you're suspecting a malignant form of pleural effusion. And we can even request for your sputum cytology. So this is requested for your endobronchial lesions. If a patient has a mass inside the bronchus, then if you submit the sputum for histopathology, you might see malignant cells. But yes, this is inexpensive. However, it has a very low yield. So sometimes we really don't get a positive result from your sputum cytology. But this is an option if your patient refuses to undergo those invasive procedures. Okay, so for lung cancer staging, you'll have to do the following. First, anatomic staging. So you'll have to locate the tumor as well as find if there is any signs of metastasis. Second, we do physiologic staging, and this is assess the patient's ability to withstand any anti-tumor treatments. And the initial imaging of choice is still to do your chest CT scan with contrast. And once you see that mass and the lymph node involvements, you can also request for the other diagnostic test. You have your positron emission tomography, your PET, or a combination of your PET scan and CT scan. So this is a very good test to do when we're looking for metastasis, especially lymph node metastasis, or if we're checking for nodules. Your cranial MRI is the test to request if you're looking for brain metastasis. Full abdominal CT scan is requested to check for liver and adrenal metastasis, while your bone scan is used to check for bone metastasis. Okay, so here we have your TNM staging. So very important for your lung cancer is to stage the patient. So the first thing you look at is the primary tumor, the tumor itself. So the stages as follows. Your T1 is a tumor that is less than 3 centimeters in diameter, surrounded by lung or visceral pleura without invasion of more proximal than your lobar bronchus. You have your T2 tumor, which is more than 3 but less than or equal to 7 cms with any of the following features: the involvement of your main bronchus but is more than 2 cms away from the carina. There can be invasion of the visceral pleura. There can be atelectasis or obstructive pneumonitis, but extends only to the hilar region and does not involve the entire lung. It's further subdivided into T2A, which is a tumor more than 3 but less than or equal to 5 cms, or T2B, which is a tumor that is more than 5 but is less than or equal to 7 centimeters. Okay? Once your tumor is more than 7 centimeters, then that's under stage T3. Or if it has any of the following features, if it has involvement of important structures which are still operable, so the chest wall, diaphragm, phrenic nerve, mediastinal pleura, parietal pericardium, main bronchus less than 2 cms away from the carina without involvement of the carina itself, then those will fall under T3. If there is atelectasis or obstructive pneumonitis of the entire lung, again, that falls under T3. Or if you have a separate tumor nodule in the same lobe. So for example, if you have a right upper lobe mass and you also have a right upper lobe nodule, then that will fall under T3. And lastly, if you have a tumor of any size that invades certain critical structures, very important structures that are no longer operable, such as your mediastinum, your heart, great vessels, trachea, recurrent laryngeal nerve, esophagus, vertebral body, carina, or if you have a separate tumor nodule in a different ipsilateral lobe, those will fall under T4. So a separate tumor nodule in a different ipsilateral lobe, for example, if you have a right upper lobe mass and you have a right middle lobe nodule, then that will fall under T4. Okay. Next is you look at the lymph node involvement. So your N. N0 stands for no lymph node metastasis. N1 is if you have metastasis in the ipsilateral, peribronchial, hilar, or intrapulmonary nodes. So N1 are the lymph nodes that are close to the lung parenchyma. Close to the lung parenchyma, peribronchial, intrapulmonary, hilar. Okay. N2 is if you have lymph node involvement of your ipsilateral, mediastinal, and or subcarinal. So N2 lymph nodes are in the midline. Midline. Mediastinal, subcarinal. So those are N2. N3 is if you have lymph node involvement of any contralateral lymph node. No? So anything that is contralateral is already N3. Also, if you have distant lymph node involvement, such as scalene or supraclavicular lymph nodes, those are very distant from your lung. So those will fall under T3. Okay, N3, sorry. And lastly, you have your metastasis. No? And so M0 stands for no distant metastasis. M1 stands for distant metastasis. No? It's further subdivided into M1A, M1B, and M1C. M1A is if there's a separate tumor nodule in a contralateral lobe. No? So for example, again, you have a right upper lobe mass and you have a left upper lobe nodule. So that falls under M1A. Also, if you have a tumor with pleural nodules, tumor with malignant pleural effusion or malignant pericardial effusion, that will also fall under M1A. M1B is if you have a single distant metastasis. No? If you have just one metastasis in any extrathoracic organ, no? Your brain, your liver, your adrenal, your bones, any organ, but just one metastasis, that's M1B. But if you have multiple metastasis, no, regardless of the extrathoracic organ involved, as long as it's more than one, that will fall under M1C. Okay? So for example, if I give you a tumor that is 4.2 centimeters, then that will fall under T2. Okay? So it's more than 3, but less than or equal to 7 cms. So that's T2. Specifically, it falls under T2A because it's more than 3, but less than or equal to 5 centimeters. So T2A. Here we have a tumor that is more than 7 centimeters. No? So more than 7 centimeters, that will fall under T3. Or if there is atelectasis of the entire lung, or if there is chest wall invasion, again, those will fall under T3. T4 is a tumor of any size as long as if you have involvement of the critical structures, no? Inoperable structures, such as your carina and your great vessels. No? So those fall under T4. Okay, for metastasis, you have here your pulmonary metastasis. These are seen as cannonball, no? Very round densities, cannonball lesions, usually seen in the lower lung zones, whether by X-ray or by CT scan. And on brain cranial MRI, we can note that there are ring-enhancing lesions. So these ring-enhancing lesions actually show you brain metastasis. You can also see hypodense lesions, which will mean that there is liver metastasis, or hypodense lesion in your adrenal gland, which would point to an adrenal metastasis. And when you do your bone scan, you would find these hot spots. So these darker areas are hot spots, which show you that there are bony metastases. Okay, so seen in your Harrison's is the stage grouping of your TNM staging based on the 8th edition. Okay, so stage 1, 1A is a tumor that is T1, no? T1, those that are less than 3 centimeters. So less than 3 centimeters with N0, no lymph node, and no metastasis. Those will fall under stage 1A. Stage 1B is a T2A tumor, N0, M0. Stage 2A is T2B, N0, M0. Again, you have your T2, which is a tumor that is more than 3 but is less than or equal to 7, it's divided into your T2A, which is more than 3 but less than or equal to 5, and your T2B is more than 5, less than or equal to 7. Okay, so T2A N0 M0 is 1B, while T2B N0 M0 is your 2A. Okay, stage 2B is a small tumor from T1A until T2B, so that's less than 7 centimeters, with N1 M0, so that's 2B. We have T3 N0 M0, so T3 more than 7 centimeters, with no lymph node, no metastasis, again stage 2B. Your stage 3A can either be T1 to 2B N0 M0, or T3 N1 M0, or T4 with N0 N1 M0. Those will also fall under 3A. Under stage 3B, you have your T1 to 2B, small tumor with N3 involvement, M0, or a T3 or T4 tumor with N2 involvement, that will also fall under 3B. For stage 3C, that's a T3 or T4 tumor with an N3 lymph node involvement. You have stage 4, which is subdivided into 4A, if it's M1E or M1B, and 4B is for your M1C metastasis. Okay? So for me, this is an easier way to recall your staging, no? So you have to know the tumor itself, no? The size of the tumor, the involvement of surrounding structures, no? And if there are any metastatic lesions. And then you look at the lymph node involvement, no? So in 0, no lymph node involvement. In 1, we have lymph nodes that are close to the lung parenchyma. So your intrapulmonary, peribronchial, perihilar. Again, this should be ipsilateral, no? On the same side of your tumor. In 2 are midline lymph node involvement. You have your mediastinal and subcarinal. No? So mediastinal, subcarinal, again, should be ipsilateral, no? On the same side of your tumor. No? In 3 are your contralateral lymph nodes. So anything that is contralateral will fall under N3. Also, if you have a distant lymph node involvement, such as your scalene and supraclavicular, those will fall under T3. Okay? So if you have a small tumor that is less than 3 centimeters, that will fall under stage 1. N0 involvement, small tumor, stage 1. If you have a T2B tumor with no lymph node involvement, again, T2B is more than 5 but less than or equal to 7. So with no lymph node involvement, that is your stage 2A. Okay. If you have a small mass, less than 7 centimeters, with N1 involvement, those will fall under stage 2B. Or if you have a bigger mass, more than 7 centimeters, or involvement of your important but still operable structures, then that will also fall under 2B. If you have a small mass, less than 7 centimeters, with N2 involvement, N2, midline, so your mediastinal and subcarinal, midline involvement, lymph nodes, small mass, that will fall under stage 3A. Or if you have a T4 mass is in any size that has involvement of your critical structures, no? Inoperable structures, that will fall under 3A as well. Or if you have a T3 or T4 tumor, involvement of your important or critical structures with an N1 involvement, those will also fall under 3A. No? So you can see the pattern. So you have 2B here, 2B here, 3A here, here, and here. Next is if you have a small mass less than 7 centimeters with N3 involvement, again N3, anything contralateral or anything distant from the lungs, that is your N3 lymph node. So small mass with N3, that's stage 3B. Or if you have a T3 or T4 tumor, involvement of your important or critical structures with an N2 lymph node involvement midline, that will fall also under 3B. And if you have a T3 or T4 tumor involving your important or critical structures and an N3 involvement, no? Contralateral or distant lymph nodes, then those will fall under stage 3C. Your M1A is if you have separate tumor nodule in a contralateral lobe. If you have pleural nodules, malignant pleural effusion, malignant pericardial effusion, those will fall under M1A. M1B is a single extrathoracic metastasis. No? So regardless of the organ involved, it just has to be one single metastasis. So those will fall under 4A. And lastly, if you have several, multiple distant metastasis, multiple extrathoracic metastasis, regardless of the organ involvement, then those will fall under stage 4B. Okay? For your small cell lung cancer, it's easier to stage because we usually use the VAS, no, Veterans Administration System staging. So it's composed of only 2 stages. You have your limited stage disease. So this is a cancer that is confined to one hemithorax. No? That's because you can encompass the area with one radiation port. So that's limited stage disease. If you have extensive stage disease, that means that there is already metastasis or cardiac tamponade, malignant pleural effusion, or if there is bilateral pulmonary involvement, or you have involvement of both hemithoraces, then that will fall under extensive stage disease. Okay, so once you have your anatomic staging, you do your physiologic staging. So you have to assess the patient in terms of their problems. You have to encourage the patient to stop smoking. And you have to check the patient's lung function, no, prior to doing any surgery. If your patient has an FEV1 that is more than 2 liters or more than 80% predicted, then this patient can probably tolerate pneumonectomy. No? If your FEV1 is only more than 1.5 liters, then this patient has adequate reserve for doing your lobectomy. But if your patient has low FEV1, you might want to do your cardiopulmonary exercise testing or CPET. And if your maximum oxygen consumption is less than 15 ml per kilogram per minute, then that means the patient is at higher risk of having post-operative pulmonary complications. Okay? So first, we have to diagnose the patient, no? Do the CT scan, the workups for your metastasis. No? And if you find that you have no signs of metastasis, and you check your lymph nodes and the stage the patient. So if your patient falls under stage 1A, so this figure tells you that surgery alone is the management of choice. If the patient falls under stage 1B, then that would depend on the size of the tumor. If it's less than 4 centimeters, surgery alone will suffice. But if it's more than 4 centimeters, then we can do surgery followed by adjuvant chemotherapy. If you have Stage 2 with N0, N1 involvement, so 2A, 2B, or stage 3A, then we can do surgery followed by adjuvant chemotherapy. And if you have N2 involvement, so that's your stage 3A, 3B, then we advise the patient a combined chemo and radiation therapy. Okay. While for your metastatic disease, so we usually subject the patient to chemotherapy alone. Okay. So this is a summary of the management of your non-small cell lung CA. Again, if you have a stage 1A or 1B less than 4 centimeters, then surgery alone will be done. If it's 1B that is more than 4 centimeters, we do surgery followed by adjuvant chemotherapy. The stage 2 or 3 with N0 or N1 involvement, so that's 2A, 2B, and 3A, we can do surgery followed by adjuvant chemotherapy. For stage 3 with N2 or N3 involvement, that's your 3A, 3B, or 3C, we can do chemo radiotherapy. And for stage 4 disease, then we subject the patient to a systemic or chemotherapy with or without your targeted therapies. Okay. So targeted therapies are now available. So this is because we have detected the presence of your oncogenic driver mutations. So if a patient has positive finding of your oncogenic driver mutation, then we can use these oral therapies which are found to have significant anti-tumor activities. So it's found to have an improved survival compared to just your cytotoxic chemotherapy alone. So all patients with advanced non-small cell lung CA, stage 3, stage 4 disease, should also undergo molecular testing to look for these oncogenic drivers, your EGFR and your KRAS. We now have your EGFR tyrosine kinase inhibitors, your osimertinib, erlotinib, gefitinib, afatinib, and lacumitinib. And these agents have been found to improve response rate as well as improve progression-free survival. You also have your immunotherapy agents. So if you recall, you have your cell cycle, and these immunotherapy agents actually block your cell cycle checkpoints. So they are checkpoint inhibitors. They block the interaction between your T cells and your antigen-presenting cells. And they have been found to improve the quality of life as well as survival of your locally advanced and even metastatic non-small cell lung CA. So examples of your immunotherapy include your pembrolizumab, atezolizumab, nivolumab, ipilimumab, and durvalumab. On the other hand, you have your small cell lung CA. So as mentioned, you only have 2 stages, your limited stage disease, which is confined to 1 hemithorax, the management of which is combined chemo and radiation therapy. So similar to your stage 3 disease in your non-small cell. While for extensive stage disease or any disease that has involvement of both hemithoraces, so these patients are usually subjected to chemotherapy with immunotherapy with or without radiation for palliation. Okay, so this figure shows you the management of your small cell lung CA. So again, you diagnose the patient with your CT scan and check for presence of metastatic disease. If the patient does not have any metastatic disease and has no contraindication to your combined chemo and radiation therapy, then we proceed with a combined chemo and radiation therapy. If the patient has contraindications to a combined chemo-radiation therapy, then we do sequential treatment. So we do chemotherapy first, followed by your radiation therapy. And if your patient has metastatic disease, then the management will be chemotherapy with immunotherapy, with or without radiation, no, for palliation. Okay, patients with small cell lung CA are also advised prophylactic cranial irradiation. No? So this is because we've found, no, that patients with small cell lung CA are very prone to having brain metastases. No? So all patients who underwent treatment and responded well, no, either limited stage or extensive stage small cell CA, they are offered prophylactic cranial irradiation to avoid the occurrence of metastasis in the brain. And lastly, we have your solitary pulmonary nodules. So solitary pulmonary nodules are usually an incidental finding on chest x-ray. So very common, patients undergo your annual physical exam or employment exam, and we would notice these small nodules on the chest x-ray. So these nodules are densities completely surrounded by normal rated lung. Yeah? They usually are circumscribed or round in shape, but can be of any shape. Yeah? And usually measures around 1 to 6 centimeters in greatest diameter. So the first thing to look at, no, if you're thinking of a solitary pulmonary nodule, is you have to check for the benign nature of your solitary pulmonary nodule. No? So if you have if you can check, no, the previous x-rays of the patient, and you notice that there is stability or lack of growth over a period of more than 2 years, then you're probably looking at a benign nodule. No? Or if you notice certain patterns of calcification, there's intense focus of calcification, or multiple punctate or dot-like foci of calcification. If you have a bullseye appearance of calcification, that's usually granuloma. If you have a popcorn ball appearance of calcification, that's usually hamartoma. No? So any pattern of calcification will probably predict a benign solitary pulmonary nodule. Okay? But if you don't have those characteristics, not predicting a benign nature, then you have to assess the risk of the patient with a solitary pulmonary nodule of developing cancer. So you look at the following features. First, you look at the size of the nodule. If the nodule is less than 1.5 centimeters, then that is a low risk nodule. If it's 1.5 to 2.2 centimeters, that's intermediate risk. If it's more than 2.3 centimeters, then that is a high risk nodule. Look at the patient's age. If the patient is young, less than 45 years old, then the patient is at low risk of developing lung cancer. But if the patient is at 45 to 60 years old, patient is at intermediate risk. And if your patient is elderly, more than 60 years old, then that places the patient at high risk of developing lung CA. Next, you look at the smoking status. The patient is a never smoker, then that patient is at low risk. Current smoker, but light smoker, less than 20 cigarettes per day, then that's intermediate risk. Or if a current smoker is a heavy smoker, smoking more than 20 cigarettes per day, that is high risk. If your patient has quit more than 7 years ago, then the patient is at low risk. Patient has quit but less than 7 years ago, intermediate risk. If the patient is still smoking, never quit, patient is at high risk of developing lung CA. And on CT scan, you look at the characteristic margins of the nodule. If the nodule margins are smooth, then that's probably a low-risk nodule. If the patient's nodule is scalloped, or the margins are wavy, then that places him under intermediate risk. But if you see a corona radiata, or a crown-like appearance, or it's sharp or spiculated, then that will place the nodule under high risk of developing malignancy. Okay? So if you have that nodule, Again, first check if there is a benign pattern of calcification or if there is stability, no, for 2 years. No? So if you see those benign patterns of calcification or stability for 2 years or more, no further testing is required. No? That is a benign pulmonary nodule. However, if you don't have those benign patterns, no, then you have to check, no, the risk of the patient developing lung CA. Okay, so if you classify the patient as low risk, then we just do serial high resolution CT scan. No? So we repeat the scan at 3, 6, 9, 12, 18, and 24 months. No? Just to monitor the size of the nodule, if it's increasing in size, or maybe if it develops patterns of calcification. If your patient is at moderate probability of developing cancer, then we do further diagnostic tests. We do PET scan if the nodule is more than or equal to 1 centimeter, or a contrast-enhanced CT scan. We can also do your transthoracic fine needle aspiration biopsy if peripherally located, or a bronchoscopic biopsy if the nodule is more centrally located. Or if your patient is at high risk, you can actually proceed to a more invasive procedure such as your VATS. Doing VATS, they can actually do a frozen section or do a histopath at the time of thoracoscopy. And if the lesion is found to be malignant, then that patient is subjected to lobectomy, removal of the affected lobe. Okay. Again, if you do your testings and they turn out positive, then we subject the patient to surgery. Okay. So that is all for your lung cancer. Thank you very much for listening, and thank you for not smoking.